So,
I hear you well.
Okay, so the roadmap, I will introduce the topic. I will talk about the burden of MDR-TB in Uganda, talk about surveillance, flow of care, treatment options, and conclude. So this disease called tuberculosis is caused by a bacterium called Mycobacterium tuberculosis. This is a very old disease. It was discovered in 1884 by a scientist called Dr. Robert Koch. So you guys, scientists think this issue of Mosaic saying they should pay scientists is real. As you can see that these are great people like this doctor who's remembered up to today for discovering this disease, which is actually was discovered in the mummies in Egypt before Christ. So the point is, how can such an old disease of long ago still bother us up to today and are unable to defeat it? This disease is caused by this bacteria, which is very unique. It is different from other bacteria. It has a cell wall, which is very resistant and keeps changing. It's antigenic. It resists cold, freezing, or desiccation, but very sensitive to heat, sunlight, and ultraviolet radiation. That is why you want to control tuberculosis, you install ultraviolet radiation and it kills this bacteria. It is also very slow in multiplying. It grows depending on the amount of oxygen and pH. When oxygen is plenty, it will divide actively. When there is no oxygen, it becomes dormant. It is difficult to kill a bacteria which is not consistent. That is why we use many drugs to manage TB. Some of these drugs will act when it's multiplying, they're called bactericidal agents. And some of the drugs will act on the bacteria when it is dormant. These are called sterilizing agents. And we treat for a long time because it can hide in areas like cavities which have poor oxygen and acidic pH, but they are not dead. So the longer we treat with TB drugs, the more likely that the blood will keep supplying these drugs until they reach the actual bugs wherever they are. So for drug-sensitive TB, the usual TB, we treat for 6 months. But for drug-resistant TB, we treat for longer than that. So now it takes me to define what drug-resistant TB is. So drug-resistant TB is a lab definition, and it occurs when the TB germs continue to grow in the presence of one or more TB medicines. Ideally, when you apply a medicine to a bacteria, the bacteria should die. So like here, there is no growth. There is a medicine here, there is no growth. However, where they have applied the medicine and the germs keep growing, that is called drug-resistant strain of tuberculosis. Now, when we talk about multi-drug resistant TB, it means that 2 of the most efficacious TB drugs, isoniazid and rifampicin, are resistant, meaning that the germ is continuing to grow despite these drugs being present. And this is very dangerous because therapy is longer. It's 9 months to up to 20 months. Treatment, therefore, is even more expensive. And we try to manage drug-sensitive TB, the usual TB, done for 6 months, to avoid going into MDR-TB. The factors that lead to the spread to drug-resistant TB include patient factors, like patients who don't take their drugs well. It's called poor adherence. The germs can become resistant. They can also be due to provider healthcare worker related. For example, if a healthcare worker gives inadequate dose or doesn't instruct the patient that the drugs are taken for 6 months and the patient takes drugs for only a month. There is also a healthcare system where drugs are out of stock, or drugs are poor quality. All these factors lead to drug resistance of these germs. So now I'll talk about MDR-TB in Uganda. What is the burden currently? So there are, in 2010, a survey was done which revealed that 12% of cases who had TB before, TB therapy before, developed MDR. But among those who were new, meaning who had never developed TB in their lives, it was 1.2%. But this is a very old survey, which we can't rely on because things have changed. And therefore, it calls for the Ministry of Health to conduct another survey to find out the actual burden in the community. However, based on these figures, at the UN high-level meeting held in 2019, the expected burden of MDR in Uganda should be at least 1,400 patients. However, currently, as we have only 470 cases of MDR, meaning that we are missing over 930 cases. About 70% are missed, so they're in the community somewhere. We must find them and treat them and prevent this spread of drug-resistant strains in the community. The gene expert is this test that diagnoses there is TB, but also goes ahead to say there is TB, but the TB is actually drug-resistant to rifampicin. It has a low utilization of 63%. So even this is a low surveillance rate. We need to ensure that all the gene expert patients that we have are used to ensure that we catch any positive gene expert, and these patients are managed accordingly. Currently, about 14 patients are untreated in this cohort. And this tells you that patients get lost between diagnosis and care. They are not all patients are being linked to get the service. So there is no use in diagnosing a condition if you cannot manage it. Such patients who are untreated, they keep spreading these strains in the community. The 2018 cohort showed that a success rate of treatment of 78%. However, the recent rate, we have just analyzed data in May, and our recent success rate is at 80%. That means that of every 100 patients we treat, 80% actually get cured, which is a good thing. But still, the 20 who die or get lost follow-up is actually high because our target is 90%. Drugs are free, diagnosis is free. We want all patients with MDR-TB to cure and not die off. So this shows a trend of enrollment since 2013 when the program began. From 2013, we had about 200 patients. In 2014, when Gene Expert was introduced, by 2016, Expert was introduced for all. Initially, it had been for only HIV. Now, Expert was rolled out for all. And so we see that upward trend in cases, in surveillance. And then when COVID struck in 2020, there was a hiccup there in lockdown because there was lack of transportation, patients couldn't access services, etc. But we have managed to live with COVID with resilience, and our numbers are picking up again in that manner. Who are these patients with MDR? So I got this from the 2019 cohort describing who these patients are with MDR-TB. You can see here that the majority are the active age group from 25 years to 54, but largely from 25 to 44, the highest there. So MDR is actually affecting the age group which are the most active. This is where people work And therefore it affects the economy in that manner. So MDR-TB, we do a mixed mode of care, as I'll tell you later. The expansion of treatment was from 3 sites in 2013. There were just 3. And now we have 17 sites to date, but there were 17 already by 2015. Each of the sites, after initiating the patient, they will identify a follow-up facility in the community to give what they call directly observed therapy to these patients. These patients are told, open your mouth, put the tablets in, and swallow when they are being observed. I like to call it directly observed tablet swallowing. Currently, there are over 400 follow-up facilities that follow up our patients with MDR-TB. So this map here shows the surveillance. We currently have 295 machines, GeneSpot machines in the country. Some were taken to support COVID-19 testing. We have 271 health facilities with GeneXpert machines on site. And in such facilities which do not have a GeneXpert machine, we have a hub system where they use motorcycles to transport these samples to the nearest GeneXpert site to ensure that we don't just test for TB, but we also test for resistance using the GeneXpert. So these machines, we would like all GeneXpert, would like all facilities to actually have GeneXpert machines so that they're able to do on-site DSTs. There are many issues that arise with the hub system. Transport today may not be there. Samples may take long at the index facility, and like I told you, sunlight, heat can actually kill these bacteria. By the time they arrive to the facility, they could have been denatured. In terms of lab, in 2012, we had one diagnostic facility at NTRL, and they were largely doing a phenotypic DST. But now there's been expansion, and with the rollout of the GeneXpert in 2014, and now we're able to do the second-line LPA from June 2017. This second-line LPA looks for resistance to fluoroquinolones, meaning before we initiate second-line treatment, we're able to detect that this patient already has resistance or not before we start them on the second-line treatment. We also have capacity now at the NTRL to do extended DST. The DST is a drug susceptibility test, a test which looks for susceptibility, meaning that does the drug kill the bacteria or not. And we do this for our drugs, bedaquiline, clofazimide, and linezolid. So the mode of care that we use to manage MDR-TB patients is a mixed mode of care, meaning that patients who are stable, they have ambulatory care. They can start their care right away at a mental follow-up facility. So identify a facility near their home. It can be private, it can be government, as long as there is a nurse or any healthcare worker who is able to administer this therapy. And now that we have the oral regimen, it is easier. Previously, we had the injection-based regimen, and they were daily injections, but now with the oral therapy, it is easier to administer these medications. Then for patients who are ill, they are admitted for about 1 month or 2. And then once they are discharged, before they are discharged, they identify a facility near their home where we send an advance party to go and do mentorship, so that by the time they are discharged, they can have their therapy at home, near in the community, at a facility near their home where they can go to every day for DOT. So this is a very expensive venture, because the patients must move from their home houses daily to take their drugs without fail. Okay, so once a month after discharge, the patient will review once a month. There's some admin, can you mute that person? So once a month, the patient will be reviewed, and there will be assessment of symptom resolution, screening for side effects. As I'll show you, so we do the baseline tests, of course. We do the sputum smear, take off samples for culture. We do CBC, RFTs, LFTs. We do ECG, because one of our drugs called bedaquiline can prolong the QT interval. We do visual acuity, and others. So because of MDR-TB having issues with the isolating patients, this just shows you that a transition that we went through to ensure that isolation units are built for MDR-TB patients. So most of these have been built. For example, you can see Masaka used to have a tent, and now they have a fully built ward. Ginger and Iganga we are in the pipeline to ensure that we get resources to build proper MDR-TB units in those facilities. This is MULAGO National Referral Hospital, which is the center of excellence for TB care in Uganda. We have the largest number of patients with MDR-TB. There are 140 of them. And this is also a home to the National TB panel, which I chair, which discusses the difficult to treat cases of MDR, supporting all the 17 sites to ensure that they get knowledge and skill to manage these patients, also the side effects, to ensure that they are retained in care and they get good treatment outcomes. So the MULAGO unit has a 39-bed capacity. So these patients in MULAGO, they are 140. It is very rigorous to manage even just one patient with MDR-TB, as I'll show you soon. So we split them in two groups of 30, so that we manage 30 patients per week, such that we see at least one patient every month. Per month, a patient is seen at least once. So that the Global Fund comes in to support patients with the transport, like I said, to attend the daily DOT at the nearby health facility. And this is also implemented. So they are given transport every day initially, and they're also given support in terms of food. And this is to improve their status of nutrition, to mitigate loss, to follow up, and prevent treatment interruption. So patients would say, Musao, I cannot take my drugs because I'm hungry, or I can't go to the facility because my legs are paining, or due to side effects of the drugs, and therefore this support was a very big boost to help with improve adherence. So they're given a refund of per month of 200,000 per month, which they use for daily DOT and also for the monthly visit at the initiating facility. They're also given dry ratio upon discharge with posho, beans, cooking oil, and sugar. And of course, MULAGO, where I work, I ensure that the quality is key to ensure that the patients get what they deserve. So this just shows that the inpatients, this is MULAGO Hospital, inpatients getting food, And these are also, this is massacre and hospitals where the dry ratio is being given out. So now I want to talk about treatment of MDR-TB. So the therapy of drug of MDR-TB has evolved from 20 months treatment to now the shorter 9 months regimen, from injection-based regimen to now the oral regimen. So the current therapy grouping by WHO groups them into 3 groups: Group A, B, and C. Where in Group A we have the fluoroquinolones, levofloxacin, omoxifloxacin, bedaquiline, and linezolid. And all these 3 drugs should be picked unless there's intolerance, meaning there is some kind of side effects, or if there is resistance. Then we have Group B, which is clofazimine and cycloserine. Clofazimine has been used, is a new drug that has been used for leprosy. It was repurposed for MDR-TB. Cycloserine, so these 2 drugs should also be picked unless they cannot be used either due to intolerance or resistance, meaning that all the 5 drugs should be used. Group C is only picked upon when we are unable to complete a regimen due to intolerance or resistance, meaning that Group A and B, the drugs are not enough. This is a thiambutal, which is a first-line drug. The lemma need a new drug, just like bedaquiline, pyrazinamide, imipenem. This one we don't use because it needs a central line. Amikacin can also be used. The only injectable now that can be allowable is amikacin when there is problems with Group A and B. And we prefer not to use the injection-based regimen. We have ethionamide and also PAS. So I mentioned the journey that we've come very far from injection-based regimen. And now, so there was this 20 months regimen that we used to use. Imagine injections daily for 20 months. And now, then we evolved now to the 9 months regimen. And now we have the modified oral shorter regimen where we use 9 to 11 months of bedaquiline, levofloxacin, linezolid, clofazimine, and cycloserine. Or, so there are 2 options, either the modified short regimen or the oral longer regimen, which is 18 months, same drugs. This time there is an intensive phase of 6 to 8 months, depending on when the culture convert of bedaquiline, levofloxacin, linezolid, clofazimine, or cycloserine. And then after that, the intensive phase, they go with the 12 months of 3 or 4 drugs of the same, depending on the level of tolerance or resistance or site disease, etc. So the criteria for selecting which option to use really will depend on severity of disease. So for patients who
Dr. Mukembo, you almost welcome. Can you take over as the presenter comes back? I just introduce the people. And then I also ask Madam Namara Elizabeth to open up more space for more people to join. The link is saying 100 people is maximum, but I think we can admit up to 200 or 300 something.
Thank you very much, Dr. Wilberforce and our participants. It's unfortunate that we don't know what has happened to Dr. Susan. Perhaps it was a network issue. Dr. Susan, are you back? I think she's still off, but I'm certain she will join back. And the unfortunate bit is the issue of the link today. I don't know why Elizabeth decided to limit it to a maximum of 100. It might end up disturbing our presenter that she might be joining when the group is full. Dear members, I'm Dr. Robert Mukembo, University Medical Officer at Gulu University. I once again wish to thank you for joining in every Friday, 8 p.m. That's when we hold our weekly CMEs. And today's discussion is very, very important to both health workers and the community. The burden of multi-drug resistant tuberculosis is a very big burden, both to our health system and even those that support it. Today I was listening to the news bulletin on NBS, and one of the Ministry of Health officials was commenting that routine TB treatment for a person is costed at about 2.5 million. But managing MDR-TB, each individual usually consumes close to 12 millions. So we can see the financial implication of management of MDR-TB. And perhaps even the cost may be higher. Now, for somebody who is not in a policy formulation, somebody who is not maybe a medic, may be wondering, what does the 12 million do? But we look at the entire chain of screening, diagnosis, treatment, follow-up, the resources used, the human resources involved, and every other thing connected with supportive management of the MDR-TB patients. So it's a very expensive disease to manage and very dangerous. It's incumbent upon us as health workers. It is incumbent upon us as a community and as a country at large that we join efforts together and put in all we can in combating this disease. We shouldn't forget we have just run out of lockdowns of COVID-19, a respiratory disease that we know also causes lung fibrosis in most of the victims. Just like TB, also, the square almost looks similar. And for somebody who is naive to COVID-19 and its pathology in the lungs, when you look at the X-ray of a COVID-19 patient, or even one who previously suffered severe COVID, you might be tempted to think this patient has TB. And therefore, updating our knowledge as health workers and embracing ourselves with the new modalities of treatment and what we need to do as a workforce is very, very important. Lisa, have we got Susan back?
Yes, I'm back. Allow me to share.
Yes, Susan, you are welcome back. I was just giving a small comment, waiting for you to join back. Kindly proceed from where you had ended.
Okay, allow me to share my screen. Sorry, somebody called me and I'm using my phone and they cut me off and I couldn't enter back because the meeting was full to capacity. Sorry for that. Yes, so I was talking about, I think, the journey, yes, of the treatment that we're now using, the oral regimen, even the modified short regimen or the longer regimen, depending on severity of disease.
Dr. Susan?
Yes?
Slideshow, please.
Okay, yes, I'm now here. Yes, so this is the issue about MDR is like, we must monitor the patients closely. At baseline, for every new patient, we do a smear, take off a smear, a sample for culture. We do culture because we want to grow the organisms in the lab and to see if actually, to reconfirm that there is actually resistance when they introduce the TB drugs, meaning there is MDR. And then we do after the baseline, we do the monthly samples for culture to ensure that the drug, that the germ does not keep growing. We want to see a negative culture every month. That's why we monitor them. We do not want to see a positive culture along the course of treatment. It can be a pointer that there is poor adherence to drugs. We do second line LPA at baseline because we want to see if there is resistance to fluoroquinolones, which is a second line drug. We'd also do a DST, which may take maybe 3-4 months to return, solid media to confirm that there's actually MDR, true MDR in terms of resistance to both pumpsin and isoniazid. We do a chest X-ray. We do a chest X-ray at baseline and at 6 months. X-ray is important. It shows the severity of disease, and it is very important for us to decide which regimen we are going to use, whether the shorter regimen or the longer regimen, depending on the chest X-ray findings. At 6 months, we do follow up to see if there is resolution of the abnormality. We do HIV testing at baseline, and after at month 3, and then again at month 12, CD4 count, of course, for HIV viral load. We do a full blood count because one of the drugs called linezolid can shut down the bone marrow and cause anemia and cause thrombocytopenia and the leukopenia. So this drug is a very good drug, but it has serious side effects, which we must monitor for. We do a blood glucose level at baseline because we know that the diabetes and TB, people who have diabetes can easily get TB because of the low immunity. We do the renal function tests. We do thyroid function tests. If somebody's on a thionamide, because it can actually cause hypothyroidism. And if it is there, we replace with a hormone. We do audiometry. This is an old test we used to do when we were in the injectable agent that we no longer use. However, for a few patients who are on the salvage regimen, who may be on amikacin, we shall do the audiometry. We do ECG at baseline, week 2 and 4, and then monthly, because one of the drugs called bedaquiline can prolong the QT interval, and this can lead to a ventricular arrhythmia and lead to sudden death. So we must monitor the heart by doing the ECG. And then we should also do, we monitor vision using the Snellen's visual chart for visual acuity, because linezolid can cause optic neuritis and cause blindness. So you can see that these second line drugs have many side effects, which if you do not monitor for, can easily lead to poor adherence. Somebody has MDR, yes, but you give them your drugs and they become blind. You give them your drugs and they get neuropathy. If you don't manage it, it can affect outcomes. So this explains why managing MDR is very rigorous, very expensive, because each individual must go through this routine at every visit. It calls for health facilities to ensure that there is enough personnel in these health facilities that manage MDR, the 17 of them. MULAGO, of course, gives support, but you have each regional referral hospital treats MDR. Wherever, of course, Busoga has 2 centers. This is the only one with 2 centers. We have Iganga and Jinja, but the others have 1 unit in each regional referral hospital. So the cost of treatment is met by a global fund. So for a patient with TB, which is drug susceptible, the cost is about 2 million shillings to manage a patient. But when they develop MDR, the cost shifts to 14 million. Now, just because somebody is paying for it doesn't mean that it is actually free. It's a lot of money that is put into this. So it is very expensive to manage MDR-TB, and we should try to prevent it from occurring to avoid such unnecessary losses. After treatment, the patients are monitored at months 3, 6, and 12 for symptom resolution, and to also pick up if there is a relapse. So the aims really are to manage the long-term complications of TB and to monitor for recurrence and relapse. The shorter regimen is likely to have relapses. But also, if you don't treat TB early, even if they cure eventually, they will have irreversible lung damage. The germs have died, yes, but there are scars in the lungs. And because of those scars, there will be complications. It's called copulmonale. They will get heart failure because the lungs have failed. And so they will present with edema, swollen feet, with cough, chronic cough because of edema in their lungs, water in their lungs. And they might be given unnecessary TB drugs, but it's really a TB complication because of delay in initiating therapy for diagnosed patients or the diagnosis. So this principle of active drug safety monitoring is now the key, because the TB drugs are taken for a long time, for MDR-TB particularly, the second line drugs, they're taken for a long time. There are many, they have many side effects. So we do what they call active drug safety monitoring, where we do both clinical and lab assessment at every visit to ensure that we detect, manage, and report suspected side effects. And this all is done to ensure that there is no interference with treatment and outcomes. So the challenges we're facing with MDR-TB is the first issue of surveillance. So the gene experts are not at every facility, and therefore we are missing many cases. Like I showed, we are managing about only 33% of patients, about 70% are missed and they're in the community. Contact tracing, we want all patients with MDR to be contact traced, go to their homes, ensure that you comb their homes. Anybody who is symptomatic should be tested for TB to ensure that there is no continued transmission in the community. We need another survey. The data we're depending on is old, for 2010. So another survey would give us the true burden of MDR-TB. We also see that MDR-TB is a standalone. We need to find a way to integrate it into the normal routine TB activities, so that it is not almost alienated and special. It should be integrated so that it is managed by any healthcare worker. Should get capacity to manage MDR-TB in their facility. We have inadequate support to follow up facilities. Ideally, we would want to be in touch with them more often, know what is happening. They should call us and tell us the patient did not come today, or the patient has missed for a week. Sometimes there are delays in that. We intertransport refer of patients. For example, we have referrals to Iganga sometimes, or Ginger, for patients who come from that side, and this can be an issue sometimes. And the aDSM implementation, this issue of monitoring side effects to ensure that there is no loss to follow up or interruption, is expensive because you must do lab tests, CBC, RFTs, LFTs, yeah, all these things, they're quite, we need resources for them. And they're often out of stock in the hospitals. So to the individual impact, what is the impact to the individual? The impact is that because the therapy is long, can be 9 months to 20 months, the therapy is long. The drugs are many. patients take almost a handful of drugs, 5 to 7 drugs. When I say 5 to 7 drugs, I mean bedaquiline can have 4 tablets, level 4 tablets. In other words, each of the drugs may be 4, 4, 3. That's a full handful. The drugs are many. They have side effects, and they may cause permanent disability. Neuropathy from linezolid, blindness from linezolid. Because this illness is isolating, patients isolate because they don't protect their loved ones, they get depressed. They lose their jobs, so they lose their incomes. And if not managed, if they don't access care or they access care late, they can also die. So in summary, there's an urgent need to halt transmission of MDR-TB in our community. Diagnose TB early using a gene expert, not just a smear, because a smear will not tell you if there is resistance or not. Start therapy early. The universal access to a rapid DST is very key. But for now, even if we don't have gene experts in our facilities, we have the hub system. Ensure that even if you do a smear and it's positive, start on therapy, but send that sample to the nearest hub to have a gene expert to have it diagnosed as MDR-TB. These patients with MDR are in need of support to ensure that they start and complete treatment. And the MDR-TB is a community problem. That is why we send them to the community, so that the community itself should be able to support them, to retain them in care until they complete their drugs. And for now, we hope that the shorter regimen may improve patients' retention in care and therefore good outcomes. Many of our patients are actually on the shorter regimen compared to the longer regimen, and we shall be sharing results very soon when we do a cohort review about our outcomes. So thank you very much. I welcome any questions.